Hello everyone, welcome to Community Medicine Insight. In today's video, we will discuss an important topic in polio eradication, inactivated polio vaccine or IPV. I will be covering the schedule and dosage of IPV in the National Immunization Schedule, what is the mechanism of action, the difference between inactivated polio vaccine and OPV, what is the importance of IPV after the OPV switch, and what are the advantages, disadvantages and the contraindications of this vaccine. IPV stands for Inactivated Polio Vaccine. It contains killed polio virus of all the three types, type 1, 2 and 3. It was developed by the Jonas Salk in the year 1955 and it was the first polio vaccine which was used globally. It is widely used in all the polio-free countries. Coming to the route and dose of IPV vaccine, it can be given either by the intramuscular route or by the intradermal route. So when we are giving it intramuscularly, the dose is 0.5 ml. And when we are giving it intradermally, only a fractional dose, that is 1/5 of intramuscular dose, that is only 0.1 ml is required. Fractional dose also produces good immunity when given in the two doses. In the National Immunization Schedule, we are using the fractional doses of IPV. What is the purpose of using fractional IPV in the NIS? Because it saves vaccine doses, because only 1/5 of the dose is required when we are giving the vaccine by intradermal route. So with the same amount of vaccine, we can protect more children. 2 doses of fIPV gives good immunity similar to the full schedule of IPV, and it is thus cost effective also. As per the current guidelines in National Immunization Schedule, we are giving total of 3 doses of fIPV. The first dose is given at 6 weeks, the second dose is given at 14 weeks, and a third dose is given at 9 to 11 months. Dose is 0.1 ml as discussed earlier and the route is intradermal. While injecting the vaccine, we have to observe the formation of bleb, that is the circular bulge that forms when the skin is stretched by the injecting fluid. But even after injecting the vaccine, if the bleb is not formed, we don't re-inject the vaccine. Whenever we are giving intradermal vaccine, a bleb is formed. This picture shows the sequence of vaccination at 6 weeks. So we have to remember that at 6 weeks and at 14 weeks, we are giving the fIPV vaccine on the right side. At 14 weeks also we are giving at right side, but at 9 to 11 months, because of measles vaccine which we are giving in the right hand, here we are giving fIPV on the left side. Coming to the mechanism of action of this vaccine, after the injection of IPV vaccine, the vaccine stimulates the immune system and the body produces the protective antibody IgG in the blood. So these antibodies prevent the polio virus from spreading to the nervous system. Thus, it protects the child from the paralytic polio. But since this vaccine does not induce the intestinal or the local immunity in gut, therefore, it does not prevent the gut reinfection from wild polio virus. And although the child is vaccinated, that can be a source of infection to others. What is the role of IPV after OPV switch? What happened in switch? All the countries which were using trivalent OPV are now using bivalent OPV, which contains only the strain of type 1 and type 3 polio virus. Because of the removal of type 2 OPV virus from the oral polio vaccine, we need to maintain the immunity against type 2 and that help will be provided by the IPV. It helps in the prevention of paralysis and it reduces the risk of re-emergence of wild or vaccine-derived type 2 poliovirus. So, vaccine-derived type 2 poliovirus is derived from the OPV vaccine only. Other important role is in case of a polio outbreak, the monovalent OPV type 2 may be used. So, if the people have already received vaccine, it will be easier to control the outbreak in a faster and more effective way, and easy to stop the virus transmission if the people are already vaccinated. Therefore, IPV helps in the future outbreak preparedness. So, to summarize, the important role of IPV in the NIS after OPV switch is that it helps to maintain the immunity against type 2 polio virus, which was removed in the bivalent OPV. And second reason is, if outbreak happens in the future, it will be easy to control the outbreak if the people are already vaccinated. IPV also plays a very important role in the polio endgame strategy. There will be stepwise withdrawal of OPV and strengthening of IPV coverage. So this phasic approach is important because it minimizes your immunity gaps and outbreak risk. We cannot stop the coverage of OPV all of a sudden. And ultimately, final goal is to completely cease the use of OPV, because OPV has a risk of vaccine-derived polio virus and vaccine-associated paralytic polio. Therefore, IPV use ensures long-term protection from the polio and zero risk of vaccine-related polio. Why there is a zero risk of vaccine-related polio with the IPV? Because it contains killed virus. So, there is no chances of having polio from the vaccine. What are the key differences between IPV vaccine and OPV vaccine? As we have read earlier, IPV is a killed vaccine, while OPV contains live attenuated virus. It can be given by either the intramuscular route or the intradermal, and in intradermal we required only a fractional dose, while the OPV is given by the oral route. IPV produces mainly the systemic immunity, while the OPV produces both the systemic as well as a strong intestinal immunity that prevents the reinfection of gut by the wild virus. Both the vaccine prevent from the paralysis. Since IPV vaccine is killed vaccine, it can be used where the patient is immunocompromised, but OPV cannot be used in such situation. The cold chain requirement is more strict for OPV because of the live component, and the cost is more in case of IPV. Coming to the advantages of IPV vaccine, as we have discussed earlier also, because of the killed component, there is no risk of circulating vaccine-derived polio virus or the vaccine-associated paralytic polio. It is safe in the immunocompromised children. Coming to the disadvantages of the vaccine, since it requires injection, a trained personnel is required, does not provide herd immunity, does not prevent the intestinal infection because of lack of local immunity in the gut, and it is more expensive when compared with the OPV. Adverse effects of IPV, it is extremely safe vaccine. Sometimes mild local reactions like pain and redness can occur. Otherwise, there are no serious adverse events. Contraindications of the vaccine include only those situations where there is a severe allergic reaction to previous IPV dose or some of the vaccine component. Minor illness is not a contraindication.